Hello, everyone, and welcome to Nothing Pink. I'm Carrie Williams, the operations director. And tonight, I'm glad that we have Dr. Applebaum. He is with Piedmont Plastic Surgery and Dermatology. And you guys are based out of Gastonia, North Carolina, correct?
Correct. We have multiple offices throughout the Charlotte area. We're actually the biggest practice in the Southeast. But yeah, mine is based out of Gastonia and Shelby.
Okay, wonderful. And tonight we're going to be talking about breast reconstruction options. And Dr. Applebaum is going to kind of talk us through what a consult would look like, things to be informed of, things to ask questions about, and then we'll go from there. So thanks for being with us.
Sounds perfect. Thank you for having me.
For
Um,
sure.
as you said, I'm out of Gastonia and Shelby, plastic surgeon, and do a fair amount of breast reconstruction. It's probably the most rewarding thing that I do. Um, Also do a mix of skin cancer reconstruction and then cosmetic surgery as well. When I'm talking with my patients when they first come in, the first thing that I want them to know is that every single doctor that they're meeting, and many of these patients are meeting multiple doctors, need to be there for them. So all the questions that they have, they need to be able to ask as many questions as they have and want to ask. And we're just here to give them the information, guide them in the right direction, and help them make an informed decision because there's multiple trees and multiple things that you as the patient have to follow down and go down different paths. And just like we were saying, at least before the recording, that some of them are for previvorships for patients that don't have the cancer diagnosis and have a genetic mutation, or for patients that have the cancer diagnosis and are trying to get treated more rapidly. So after that, at least short discussion with them saying that we're here for you and we want you to make the decision yourself to do the best you
So
can,
important. Yes.
um, we'll go into different things that will happen. So if a patient's coming in that say has a BRCA mutation or a check mutation, anything that may necessitate some form of mastectomy or something in the future. Um, First things first, from my standpoint, I'll have the patient come in to see me before they even meet the breast surgeon, or the breast surgeon will send them directly to me. And we'll talk about options. And the basic options for these patients is not too far off from the cancer patients as well. The main thing that they have benefit that they have on their aspect is time. They can take as much time as needed and go as slow as possible because thankfully there's no cancer at the moment and everything's perfect. Um, Now, with that, doing the reconstruction depends on multiple things. So, for a lot of these patients, if it depends on the breast size, the overall flaps that the plastic surgeon is left with. So, most of breast reconstruction is really dependent on those flaps, and that can be up to the anatomy of the patient themselves. That can be up to the breast surgeon and how aggressive they are. That can be up to the amount of fat that the patient actually has underneath the skin, which all of these are very important because everything that a plastic surgeon does relies on blood supply. And without a good blood supply, we're fighting an uphill battle no matter what we do. So for the patient that is coming in has a genetic mutation, we'll talk about, generally speaking, attempt to do a nipple sparing mastectomy. If we're talking that they've committed to a mastectomy, they want to go that route. We'll talk about potential nipple sparing mastectomy, and I try and do that every time as often as possible with my breast surgeon. The main limiting factor in that is breastosis. So if a breast is ptotic and is hanging down, you can't really do a breast reconstruction without doing something first, because if you do, say, implant based breast reconstruction or autologous breast reconstruction, so your own tissue, you're going to have a mound on your chest that looks like a pancake and looks completely abnormal with the nipple hanging down below that. Nobody wants that. So if a patient's coming in before, oftentimes what a lot of us will do, and what I do, is either a mastopexy or a breast reduction to get the nipple in an appropriate position beforehand. This ends up delaying the blood supply and allows the blood supply to incorporate better before you do anything else. And again, you have the luxury of time on your hands, so you can wait as long as needed. Honestly, the minimum people wait is 3 months. My preference is wait about closer to 6. It's just a little bit safer. And I know a few surgeons that wait honestly a year before doing anything after the fact. Then
That's between when you would do a breast lift.
and go for the mastectomy.
Okay. So breast lift, if that is needed, would be prior to a mastectomy, correct?
Correct, correct.
Yes.
And that's so that we can save the nipple if the
Mhm.
breast itself is tautic.
Okay.
If the breast is in an appropriate position, we don't have to
Mhm.
talk about that at all. And that's perfect. But oftentimes we don't know until we do an examination and take a look at
Sure.
everything and see what we need to do.
Mhm.
If there's no ptosis, or even if there's pseudotosis, which means the breast itself, not the nipple, is below the IMF, the actual strength layer of the breast, that's perfectly fine because that just means that there's some excess skin that we need to take out, but don't have to talk about doing lifts or reductions or anything, as long as that nipple's in an appropriate position. So once you get past that point and you wait that period of time, you're then talking to the breast surgeon about doing your mastectomy. And hopefully at this point, you can do a nipple sparing mastectomy and try and save that nipple instead of committing to a skin sparing mastectomy because a patient that doesn't have a diagnosis of a cancer, you'd like to try and save the nipple as often as you can. Um, there are newer reports. I personally haven't done it yet. I'm a little fearful, but of doing a free nipple graft where we will take the nipple areolar complex off of the patient's body and put it back on as a graft. Very, I don't want to say it's commonplace, but it's sort of common to do in breast reductions when we have patients that have very pendulous breasts that the nipple may be threatened at the time. So, I mean, I've done that tons of times. However, not something that people will traditionally do in mastectomies because the blood supply and soft tissue can be so thin that it's risking at least the blood supply there. But there are times when there have been multiple articles, at least recently, that some people have reported that working perfectly fine. So it's another option that we have at least developing.
Okay. Good
Um,
to know.
Going down sort of that algorithm, this is where I'll sort of split off in between to patients that have a genetic abnormality or genetic mutation and to patients that have a malignancy. So, because this is where they'll converge a little bit when we're starting to talk about the mastectomy. So, when you get to the mastectomy portion, as I said, there's either skin sparing mastectomies or nipple sparing mastectomies, just like it sounds. One, you spare the nipple. The other one, you try and spare as much skin as you can. That's the breast surgeon. But the nipple has to be taken away. And a lot of times, if you're in the cancer tree of that, it's a little unavoidable because your hand is forced from a time frame standpoint because you want to treat the cancer as quickly as possible.
Mhm.
Now, that doesn't mean that you can't do nipple reconstruction later on, but you sort of need to tackle what you have in front of you. So going forward down that tree for both types of patients, the first thing I'll usually talk about is implant-based breast reconstruction. So implant-based breast reconstruction is the most common form throughout the US. About 80% of breast reconstruction is done through implants. When going that route, there's different types. You can do direct to implant, which is that final product that you'll have of the implant. You can do a two-stage, which is a tissue expander and then an implant, or you can do a delayed where you don't do anything, let it heal flat, and come back later on and potentially do a tissue expander. And again, this gets very confusing because there's multiple different things that we can do, and I can definitely get into the weeds with all of these. So I'll try and give you the 1,000-foot view of everything. With the tissue expanders, generally what I'll suggest to patients is as long as they know they want a reconstruction, it doesn't matter really any type, if you're talking implants, your own tissue, or anything in the future. I generally recommend putting a tissue expander in place as a spacer because it helps hold that pocket and keep and retain the actual shape of the breast, making the reconstruction down the road much easier on both the patient and the surgeon. So it helps you increase the likelihood of success overall.
Mhm.
Now, for the patients that have a good blood supply, and we'll start with this sort of direct to implant. For patients that have a great blood supply, so we'll use a machine during the operation called a SPY angiography. It's one of the brands. There's multiple different brands out there. That's just what we have at our hospital. It will assess the blood flow to the actual skin flaps and tell us, okay, is there blood getting to this area? And if not, it's completely black because there's no blood flowing. And if there is, it lights up bright white and tells us that, hey, there's a good blood supply. So if there's a good blood supply and the patient is not ptotic and all the tissue is appropriate, we can talk about direct to implant, which
Hmm.
helps save the patient a step. Now, though, direct to implant has its own limitations because the bigger you go with direct to implant, the higher likelihood you have for risking or compromising the blood supply to that skin flap. In addition, if you go direct to implant with too large of an implant, you have the possibility of bottoming out. So that support structure at the bottom of the breast may not support the actual implant,
Hmm.
or potential flipping if the pocket itself isn't completely formed to the actual implant. So it's a fantastic option, but it's not guaranteed to be a one and done type thing that most people want.
Right.
Even in the best case scenario where great blood supply, great flaps, great everything, it's not uncommon to have some hollowing right in the superior medial fold right here. That is one of the most common things to have for all of these patients. And it's not that hard of a fix. It's not terrible. It's just fat grafting later on. But again, it goes back to it's not a one and done surgery for a lot of this.
Right.
With the implants, the main thing is if we have a patient that knows they have a genetic mutation or genetic abnormality, they um, come in and say they're in their 20s, 30s, and younger patient, these implants are not permanent devices. So the adage that patients will sometimes hear, oh, you need to switch them out every 10 years, it's not the case. It's really once you start having a problem with the implant. So when you're looking at rupture rates, when we're looking at capsular contracture, your body
Hmm.
naturally forms a scar around these implants, both the tissue expander and the actual implant. And that scar is both our friend and our enemy. So the scar helps support that implant and retain the structure of the breast. But every single scar in your body, outside, inside, doesn't matter, has one single goal. That goal is to get smaller and tighter. So since a breast implant is a soft device and it's something that's malleable compared to if you're talking about a knee replacement or a hip replacement, it's something that can get deformed. So you can start seeing rippling or migrating up on the chest, and it can even
Hmm.
cause pain. This is something more common in the cosmetic realm, but definitely something we see in the reconstructive realm as well. Um,
Hmm.
and it's one of the main reasons that we will switch out implants with time. That and then potentially rupture. Now, the rupture rates of a lot of the implants nowadays are fairly low. At 20 years, for a lot of these, you're looking at 15-ish% right around there. So they're sturdy implants. And I definitely show a lot of my patients, I'll stretch that implant honestly almost as wide as my arms will go when I'll show them the implants and talking about them. But again, just to go with, they're not permanent devices. Uh, One thing I'll talk about lastly with implants before going into the tissue expander 2 implant realm is implants, and I tell this both to my cosmetics and my recon patients. There was a recall on a Allergan implant a while ago. So there was one breast implant that was textured that was causing a lymphoma and had to be taken off the market. It was how they were processing it. It was just one brand and one type of that brand specifically. I didn't use it. I didn't think it added a ton of benefit, but it was pretty popular globally. And even in Europe, they're still using it constantly. And
Hmm.
throughout the entire world over the past 25, 30 years, there's about, I think, 350 to 400 cases worldwide so far. But in the US, no one's really using these textured implants anymore just because we don't want to take that risk of a potential lymphoma, even though it's exceedingly rare. Once those implants were removed, then the lymphoma resolved and it was perfectly fine. And these patients had no problems afterwards. But that was, again, more in the cosmetic realm, but still a risk in the recon realm because it was a textured implant with that specific brand. But they never saw it with any of the other brands. That brand is still one of the most popular throughout the world and is a fantastic brand. I still use it, but not that specific model because, again, never found benefit and because of the downsides.
Sure.
Going into tissue expanders, so in its most basic form, like I said, I describe it as a space saver. And it's sort of that gateway to multiple types of reconstruction, really any type that you want to go to. So there's not a ton of downsides aside from the uncomfortable nature of a tissue expander. I'll tell a lot of patients that a lot of people refer to it as an iron bra. It is not comfortable. It doesn't look great. It has one job, and it does that job very well. Everything else, it doesn't do that great. And that's across brands. Honestly, I've used some brands that are a little bit softer and a little more comfortable compared to others over the years. But overall, it's still not a comfortable thing. You're stretching this tissue out and it's just uncomfortable, a ton of pressure. Obviously, I don't know from personal experience, but I have this from my patients and they tell me this. But it's not a comfortable thing. And when patients will say, oh, it looks a little weird here or there, we generally have to remind them that, hey, this is not the final construct. This is something that I'm using to stretch out the area and allow it to accommodate either an implant or a free flap in the future so that it can appropriately be contoured and look the best that it can in the future. And patients understand and sadly get through it, but we have to do fills, and I'd say fills take anywhere from 3 to 8 weeks, depending on the volume. And every single time a patient comes in, I'm asking them, oh, be cognizant of the amount of volume you have in here right now. So if you like it, we can stop. If you don't like it, you want to keep going, we can keep going. It's again, harks back to we can just give our information and it's completely up to them. And I'm happy to do whatever they want as long as it's safe and keep going forward and get them to their final result.
Can I ask you a question about that?
Yeah.
So with the expander, say a woman was a size D when she had her mastectomy. The
Yep.
expander gets put in, but she actually wants to be smaller. Say she wants to be a B.
Yep.
So with that expander, would she be able to decide, okay, this is a B cup. This is about the size that I would want. Is there anything that has to do with like filling that pocket that would need to happen with the size of the expander getting to fit the pocket of the breast? Am I explaining that
Oh
right?
no, it's a great question. It's a great
Okay.
So there are a ton of patients that come in and will have double D, triple D, a J, an F. So very large breasts that'll say, hey, can I have a B cup? It really depends on their overall anatomy, not just necessarily the breast, but the chest wall itself. So the first thing I'll talk to them about is this B cup going to fit your chest wall? Because if it's not going to fit the chest wall, then we sort of need to pivot a little bit. And it's not that you're going to have a lot of projection out this way from your chest, but it needs to be wide enough on your chest so it fits your chest wall. So it can overall be a B cup, but the number will be different. So a 36, 38, 40, what have you.
Yeah.
But no, that's definitely possible. So it all deals with the amount of skin we resect, the skin that we cut off, and then how we form that pocket. So with the tissue expanders, that's the beauty of it, honestly. You can stop if you want to, if you're at a volume that you're happy with. If you have a 500 cc tissue expander, you could stop at 300 cc's if you want. There's nothing wrong with that. You can also blow up that 500 cc tissue expander to 800, 1000 cc's. You can get them pretty big before risking rupture or anything. Definitely with some colleagues have filled them up as big as we can, and you get to the size of a basketball. And yeah, not that anyone would want that, but it's a possibility and they're pretty durable. But yeah, we can definitely make them smaller. That's not a problem. It's really the pocket control overall, and that goes into the consultation that we have. So I'll always ask the patients, what breast size are you now? What would you like to be? What do you not like about your breasts? Is there anything that currently bothers you? And it sort of helps us plan down the road and for the future. One thing that, yeah, of course. One thing that really helps us control that pocket is something called acellular dermal matrix, or ADM. It is tissue from a cadaver that's been decellularized. Many companies do it differently. Some use radiation, some use sterilization products. There's multiple different ways to do it, and multiple companies out there. A lot of them are fantastic. Some of them not as great, and different plastic surgeons lean toward different things. The main thing is you want something that's thin, pliable, stretchy, so that it can act like a breast and expand with that expander. This incorporates into your tissue and helps control that pocket. So if we are going above the muscle or below the muscle, and I know this is always a discussion for a lot of people and is a discussion with my patients as well, you're incorporating that in some shape or form. So commonly, if you're going above the muscle, you'll wrap this tissue expander in some form or fashion. So you'll either lay it over the actual expander, or my preference is to do sort of a wonton wrap over this expander where you're covering all of the aspects of the expander itself. From there, these expanders, and we go over this in the consultation, show them the expander has multiple suture tabs where we secure it to the chest wall itself so that it doesn't move out of position. Now, can it still move out of position? I've definitely seen it. I've had a bunch of colleagues also that they've seen it too. It's always a possibility because it's a few stitches holding the expander in place until that ADM incorporates into your soft tissue. And that can take upwards of 12 weeks for that to truly incorporate completely. And even when we do switch outs and things, sometimes there's ADM that's unincorporated. If it is unincorporated, we'll commonly trim it out so it doesn't cause any issues later on. The main issue that it ever causes if it's unincorporated is you have some extra serous fluid, which is naturally producing fluid or your body produces natural fluid because it's trying to fill up a space and because there's a foreign device in there. That can go the wrong way and create a large seroma, which is just a big collection of this fluid, which may require drains or having a drain in the future. That's really the biggest downside if you have retained ADM. But oftentimes it's perfectly fine. There's always some serous fluid when you're doing a switch out. You suction it out, it's perfectly fine in the long run. With that, though, at the first operation, we're always putting a drain because since you've taken out all of this tissue now, it's going to fill itself up with fluid no matter what you do. If you do an implant, if you heal flat, if you put an expander in there, it's always going to want to fill with fluid because all the breast tissue is no longer there, and that's what your body will naturally do. So the drains are the biggest evil for a lot of patients for all of this. They cause the most nuisance. They tug, they pull, they're uncomfortable. Every patient wants to get them out as soon as possible, which is totally understandable. But definitely make sure that you're talking to your surgeon and saying how much is coming out of the drain, because if you don't want it to be pulled too late or too early. So if it's pulled too late, you're risking an infection because you don't want it to stay in too long. So I'll always pull mine at the very, very latest 3 weeks, even if a patient's producing a large amount of fluid, because we have a lot of data that shows the infection risk goes up at that point. Oftentimes I'm pulling my drains at 1 to 2 weeks, depending on the fluid output. But you need to make sure that you're staying on top of how much it's putting out, because if it's putting out more than you realize or putting out a good amount, you can have a chronic seroma there that could necessitate going back to the operating room. And that becomes a whole other problem in itself. Going back to tissue expanders, not only can we go above the muscle, but we can go below the muscle as well. And out of caution and some data to support it as well with the extra tissue, if I have a patient that I know is getting radiation, obviously this doesn't go back to the previvorships, but if I have a patient that I know is going to get radiation at some point, oftentimes I'll go subpectoral. So what we'll do is take that ADM and make a sling out of it at the bottom of your pectoralis, your chest muscle right here. We'll lift that muscle up, put the tissue expander underneath there, and sew that ADM as a sling to help create that lower portion of the actual breast itself. As it expands, then you'll fill that out. Generally, going under the muscle is far more painful. People have done it for years and decades, so it's a common practice. It really is. But it's compared to going above the muscle, it's more painful because you don't have to, going under the muscle, you have to detach the muscle, and you feel the actual expansion far more if it's under the muscle because it's activating those stretch receptors. With going under the muscle, like I said, I'll generally do it if I know the patient is planning for radiation before their operation. But there's multiple other things that go into the radiated patient. Radiation is pretty much the devil for plastic surgeons. Radiation and smoking. Any nicotine drastically increases the risk for any complication tenfold because it's affecting the blood supply. And patients that are using nicotine, we have to have a frank discussion that they may need to heal flat because whatever we do, there's a high risk of it just failing and not being successful. the way I'll describe radiation for all these patients is radiation never gets better. It only gets worse as time goes on. The blood supply, if you were to cut a radiated breast compared to a non-radiated breast, will oftentimes bleed a little bit more, but it's not good oxygenated blood. And that's what we rely on for healing any wound whatsoever. And that's the same reason that nicotine hurts everything, because you don't get good oxygenated blood to these areas. So making sure that if there is a radiated patient, once we get to the radiation aspect, we talk about bringing in healthy non-radiated tissue into the area. That could be either autologous tissue, so your own tissue that you take off a blood supply and attach to a new blood supply, or it could be regional autologous tissue, so something like a muscle from your back that we can rotate into the breast to diminish the risk of breakdown and other complications. I know it's getting a little muddled and there's multiple things that we're going down, but still going down that track of implant-based breast reconstruction overall.
Yeah.
So once we have this tissue expander in, we'll generally do fills on a weekly basis until we get to that ideal volume that you want. And if it's a B, it's a B. If it's a D, it's a D. It's whatever you want to do and whatever fits your frame appropriately. I had a patient today asking, "Oh, should we go bigger? Do you think it's going to look abnormal?" And I said, "It will still fit your frame. We could go probably about 150 cc's bigger, 100 cc's bigger, but it is entirely up to you what you feel comfortable with." And as long as it's looking appropriate, all of us are trying not to steer patients in the wrong direction.
Sure. I
With
do have a question about going bigger.
Mhm.
Are they able to, so say you do a fill, you go bigger, and then you have that fluid for a week and you're like, no, this was too big. Can you like size down?
So you can take fluid off of the expander. You definitely can.
Yeah.
Um, you can size down. It's fine.
Yeah.
Once you get some time, that skin will contract down a little bit more.
Okay. Yeah.
But even when you're working on the pocket, if the skin does not contract down appropriately, you can do things called capsulorrhaphies. So tightening the capsule itself to better
Mhm.
shape that actual breast and implant.
Okay.
So we try, a lot of plastic surgeons try and get this as close to perfect at the time of putting that tissue expander in preparation for the implant,
Sure.
but it's not uncommon that we have to do things called capsulorrhaphies, capsulotomies, partial capsulectomies, and that's all making the capsule tighter, opening it in certain spots, taking portions of the capsule out, all to craft this aesthetic breast that we're trying to craft.
Sure.
So we try and do this hand in glove fit as much as we can at the time of the tissue expander placement, but there's invariably things that we have to do to make sure that everything's as perfect as possible.
Okay.
Yeah.
Thanks.
Oh, good question. Good question. Um, but yeah, we would do these fills, and then I'll generally have patients, as long as there's no radiation involved, hang out for 3 months afterwards, just so that tissue can accommodate and that blood supply can regenerate appropriately. And then I'll bring them back in the office, usually at the 2 month mark, because if we can do surgery at 3 months, I know they want to get it out as soon as possible. And we will talk about either a tissue expander exchange for an implant, or potential, if there is radiation or anything like that, going over free tissue transfer or local regional tissue, what have you. So there's tons and tons of options that tons and tons of surgeons will talk about. It's really whatever you and your surgeon are comfortable with together. So again, it's your choice ultimately, and they're there just to give the information for you. And I have patients that only want free flaps, and that's totally fine. And I have patients that only want implant-based breast reconstruction, totally fine. But we'll just go over the risks of everything overall.
Mm-hmm.
The most common thing to really need after, so sticking again, implant-based breast reconstructions, to need really with that I'll do with the implant at the exchange will be fat grafting, sort of like I was talking about before, just from that superior medial pole having some hollowing in that area. So I'll commonly combine both of those and potentially do some lateral chest wall excision as well. So it's not uncommon that there's excess skin or fat or anything on the chest wall that's outside of the breast in itself. Oftentimes, we will extend that incision and try and cut some of that out to better contour the overall breast so you don't have sort of a breast and then a dip and then a lump or anything like that, which is fairly common and can be easily taken care of. Going from the implant-based breast reconstruction to autologous breast reconstruction, sometimes or oftentimes, depending on what center you're at, sadly, we don't have the staffing and things where I am to do the free flaps. But there's many patients that can do free flaps at the time of mastectomy or do them later on. And as I was saying before, that tissue expander is a great space saver because it allows for that free flap to be placed later on, and for you to control the pocket better. Now, free flaps is just taking one portion of tissue with its blood supply. So you're unhooking that artery and vein from where it was attached to the body, taking it off, and then removing a small portion of rib and hooking it up to the artery and vein in that spot. It's a longer recovery. Often patients will hope and think, just like if you're doing direct to implant, that this is a one shot and you're done. Oftentimes there's little adjunctive things that you have to do afterwards. And it's not like the implant that you have to switch it out because the patient's 20 or 30 years old. It's more, oh, there's hollowing or contour deformities, so we need to do some fat grafting. So nothing excessive or worrisome, but there's oftentimes little things that you need to take care of after you allow the free tissue to settle. In addition to that free tissue, unless there's enough support being placed there, sometimes that free tissue can, what we call, bottom out a little bit more, just like an implant, or it can go below that support structure of the breast, the IMF. To sometimes minimize that risk, we'll put extra support in that area, and make sure it's as strong as possible because the weight of either the tissue that you're bringing in or the implant can weigh down on that. One thing that I know multiple colleagues of mine and myself at least had concerns about, at least initially, was a implant that was released by one of the companies that was a much larger implant. So until about a year and a half ago, the largest approved implant on the market was 800 cc's. One of the companies came out and they now go up to 1450. This is mostly for patients that have, again, like I was saying, that wider chest wall. And that you would put an 800 cc implant and it just would not do the job. It would not fill out the space appropriately. And the fear that a lot of us had as plastic surgeons was that this was going to be too heavy and it was going to cause things to bottom out and you wouldn't be able to support this area. I've used it in a fair amount of patients since this came out, and had great success with it so far. Thankfully, no bottoming out. I have patients, I think the first one in North Carolina or Charlotte to use it. And so I have patients that are a year and a half out since it came out, and they're all doing perfectly fine. No bottoming out, thankfully. But I talked to all of them about it beforehand that, hey, I haven't used this implant. It's brand new. I can't tell you definitively. I have years of experience with these other implants, but with this being brand new, I can't tell you 100% that this is the exact results you're going to get. And all of these patients at least wanted to try it, and thankfully all of them have been doing fantastic. Right. Continuing with at least the autologous reconstruction after the expander. This is, again, very lengthy operation. Oftentimes you'll have to spend minimum 24, more likely 72 hours in the ICU for monitoring. Not the most fun thing in the world, because oftentimes nurses will be waking you up every hour on the hour to make sure your flap is alive and doing well. The most likely time for it to fail is within the first 24 hours. So at that point, the surgeon would bring you back and do a revision or take a look and see what's going on. It can be a problem with the artery in the first 24 hours if there's any perfusion issue. After that, you're usually seeing a problem with the veins, so things getting purple and heavy and a lot more fluid buildup. But still warranting you going back and taking a look overall. They're fantastic results with it, but it's every patient's decision on what they want overall. The free tissue transfer is great for the radiated patient, again, because you're minimizing that risk of radiation by bringing in the healthy tissue overall. A lot of us will oftentimes use that latissimus, that back muscle, as sort of a lifeboat in case there is any problem, one with implant-based breast reconstruction or with a free tissue transfer. It's sort of that, again, lifeboat, just in case anything goes wrong, we have that in our back pockets to really move things around and try and get you an appropriate reconstruction. Questions so far? I know I've gone all over the place here a little bit.
You've covered a whole lot for sure. And there is so many different scenarios,
Mm-hmm.
as you've mentioned, and so much based on the patient's body type and needs and hopes, and whether they had radiation. And so a lot of different scenarios that it's always important for a patient to talk directly to their care team. And the point that you made earlier is that the care team is there for the patient. And that's so important. And that's what we talk a lot about here at Nothing Pink, and really try to empower women to get informed, understand their options, and have a team that will hear them out, answer their questions, and help them reach their goals. Because a lot of them have gone through very traumatic experiences, whether that is understanding their family history, or loved ones going through diagnosis, themselves going through chemo, and all. There's a lot that goes along with all of this. So I thank you so much for your time and your explanation, and so glad that you could join us.
Yeah, happy to. Thank you for having me.